for this Health and Wellbeing Board meeting on Thursday, 14th of March, 2024. Sorry for the small, short delay. As ever, we will begin by a round of introduction. And when you introduce yourself, please press the mic on, and when you are done, switch it off. And I am the chair. My name is Paul Egil-Shelvin, Councillor for Cramlington South East.
I'm Graham Size. I'm a GP in Alnwick. I'm a clinical lead for North East and Cumbria ICB, placed in Northumberland.
Hello, I'm Veronica Jones. I'm a county councillor and the portfolio holder for Improving Public Health and Wellbeing.
Morning everyone, Jill O'Neill, Executive Director Public Health, Northumberland County Council.
Hello there, I'm Wendy Patterson. I'm the portfolio holder for Caring for Adults.
I'm Sarah Zaraga, Senior Manager for Business Transformation and Governance in Adult Services, County Council.
Neil Bradley, Executive Director for Adults at the Council.
Good morning, Sheree McCartney, Group Nurse Director for the North Locality for CNTW Mental Health Trust. Thank you.
Morning, Peter Stanfield, Chair of Health Watch Northumberland.
Good morning, I'm Jeff Watson. I'm portfolio holder for Healthy Lives for the County Council.
Hello, I'm Ross Wigham, an Exec Director at Northumbria Healthcare, and I'm here for Alistair Blair today.
Good morning everybody, I'm Steve Kennedy, I'm Assistant Chief Fire Officer at Northumberland Fire and Rescue Service. I'm here on behalf of the Chief Fire Officer, Graham Binnon, who I would just like to say appreciates he hasn't been able to make the last few meetings, but still wants to reiterate he's a dedicated member of the Health and Wellbeing Board. Thank you.
Good morning, I'm Graham Wright, Director of Children's Social Care, Young People and Families at the Council.
Hi, I'm Hilary Snowden, Executive Officer of Northumberland Local Medical Committee.
Good morning, I'm Brian Mulder. I'm representing Victoria McFarlane Reid from Newcastle Hospitals and should like to offer apologies this morning.
I'm Heather Bowers, Democratic Services Officer.
Four reports, which means that you are very welcome to ask questions, make suggestions, and the speakers will be very happy to provide answers and responses, and we will take them forward. So the first item, apologies for absence.
Yes, Chair, A. Blair, A. Conway and M. Purvis.
Thank you. Can I propose that minutes of the last meeting as a true record? Is that okay? Thank you very much. Any disclosures of interest? There is one received. Yes. Thank you, Peter. Yours is noted. Yeah. Would you like to say anything?
Just to say that I declare an interest in items 4 and 6, as I'm employed as the Chief Executive of Abbeyfield Northumbria. We provide residential residential care and supported living accommodation across Newcastle and Northumberland.
Thank you, Peter. Anyone else? That's all. So that takes us to the first main item, Northumberland Adult Services Self-Assessment. That will be presented by Sarah Saraka, but before that, Wendy Patterson will be introducing it. Thank you, Wendy.
Thank you very much, Chair. And good morning again, everyone. Northumberland County Council has produced a self-assessment LASER document in order to look at our strengths, our needs, and how adult social care services meet the 2014 Care Act legislative requirements. The document is quite extensive, but it is extremely informative, and as a council, we are committed to providing high-quality adult services. So I'm now going to hand you over to our Senior Adult Social Care Manager, Sarah Zariga, who's going to take you through the document. Over to you, Sarah.
Thank you very much, Wendy. Thank you very much, Wendy. So I'm going to take you through a presentation about the document that has been included as part of the papers. The document was originally called a LESER from CQC. So this document is something that we have been asked to complete by CQC. All local authorities in England have been asked to complete it. And it is a self-assessment. Originally it was called a LESER, but CQC are starting to refer to it now as just a self-assessment, so it comes under both terms. There we go. So the things that I'm going to cover as part of the presentation is the legislative context and why we are being inspected by CQC, the CQC assessment framework, what our preparations have been in preparation for CQC, the self-assessment itself, and then a timeline. So regarding our legislative context, the Health and Care Act of 2022 gave the CQC the regulatory powers to assess local authority delivery, and this is set under Part 1 of the Care Act 2014. The CQC is the independent regulatory body of health and social care in England, and they have the responsibility and the regulation of providers, local authorities and integrated care systems. And the assessment of local authorities actually commenced on April 1st, 2023. So the single assessment framework is something new that covers all providers, local authorities and integrated care systems. So previously there was different assessment frameworks, and CQC have now changed it to be one single assessment framework for everyone. There are 5 key questions that they cover. So are services safe? Are they effective? Are they caring? Are they responsive? And are they well led? And for the local authority assessment, there's 9 specific quality assessments that they will assess us under. For providers, there can be up to 25, 30, but for the local authority, there's 9 specific quality statements. When we've been assessed, we will be rated, and we will be given 1 of 4 ratings: outstanding, good, requires improvement, or inadequate. So this diagram is something that CQC provided when they first sent through the instruction about the assessment process. So right at the top of this triangle, we've got the 5 key questions that we mentioned, and these are the I statements based on what our residents, our people expect and want from us in adult services. The we statements are the quality statements, and I'll take you through the 9 quality statements that we're assessed against, and this is how we respond to and provide our services. The next section is the evidence, so this is people's experience of adult services and the service that they receive, and this comes from feedback from the client themselves, staff, leaders, partners, and any observations, processes and outcomes. And then finally we have the evidence in the form of data and information. So I mentioned that there are 9 quality statements. These come under 4 key themes. So the first theme is working with people, and it has 3 quality statements. They are assessing needs, supporting people to live healthier lives, and equity in experiences and outcomes. The next theme is providing support, and this is care provision, integration and continuity, and partnerships and communities. Then we have ensuring safety, and this is safe systems, pathways and transitions, and safeguarding. And finally we have the theme of leadership, and under this we have governance, management and sustainability, and learning, improvement and innovation. So our preparations for our self-assessment. So in order to prepare to put together our self-assessment, we established a core team. We have had continuous involvement from our senior management team, and we have put together an internal CQC lead officers for each of our key teams and services within adults. We've also produced something called quality statement returns. So these are for each of the services within adult services where they can provide evidence of how they meet the 9 quality statements. We've reviewed and updated all of our policies and procedures. We've established a CQC evidence library, so this is basically a repository of all of the documentation that we would use to evidence how we meet our quality statements, and then we produced our self-assessment document. So just a little bit then about the self-assessment itself. So it is a comprehensive overview, as Wendy mentioned, of how we meet our legislative requirements. It aligns to the 4 themes that we've covered. It's underpinned by all of our internal evidence library, and we update it as a minimum on a quarterly basis. It's made up of all about us in Northumberland, so that's the first section. Then we cover our key strategic priority areas. We cover what our key strengths are, and then we cover what we believe are our risks and challenges. So in the About Us section, it includes our local demographics, identifying our ageing population. It also covers reference to our market position statement, and it summarises the health and care needs of our population. It references our corporate plan, and it's underpinned by our corporate vision and priorities. And it also includes examples of integration with our key stakeholders. Listed here we have our key strategic priority areas. I'll not read them all out to you, but just giving some examples, we've got things like support for unpaid carers, we've got preventative support, we've got our system-wide solutions to hospital capacity issues, and we've got engagement and co-production. So I've just picked out a few of them there. Our key strengths, again, we've got things like our strong integrated services and partnership arrangements, we believe is a key strength. Our Social Work Academy, we believe is a key strength in Northumberland. And our Safeguarding Partnership and Innovative MASH, our Multi-Agency Safeguarding Hub, we believe is a key strength. Again, I've just pulled out a few of them there. And then our key risks and challenges. So these, we believe, are workforce capacity, engagement and co-production, strengths-based approach, direct payments, our housing solutions, technology, and our carers. So a timeline. So CQC undertook a pilot of 5 sites between April and September 2023. And from that, they established what their assessment process was going to be. So they had an original assessment process and they made some changes to it following those 5 pilots. They then indicated that 20 further local authorities were going to be inspected between September and April, and the announcement of those 20 local authorities started in January, and it turned out that Northumberland was one of those 20 local authorities. So we received notification that we were going to be inspected on the 19th of February 2024, just last month. Immediately we had to complete our what is called our local authority information return. And we had 3 working weeks to complete that, and that was 38 different separate items of information that we had to provide back to CQC, and each separate item had elements within it. It was a very comprehensive information return, and that was submitted on the 8th of March. We have been advised that we will be notified of when our site visit will take place. So there's 2 parts to it: the information return, which we've just completed, and then it follows up with the site visit. That will be at some point within 6 months of our notification date. So our notification date was the 19th of February. So at some point from the 19th of February through 6 months, we will have our site visit, and they will give us 6 to 8 weeks notice of when our site visit is going to be. So that takes us to the end of the presentation. So from our perspective, obviously the self-assessment has been included as part of the pack, but it was to get feedback from our providers and partners, and we've presented our self-assessment in lots of different forums. So we've been to provider forums, we've presented it to our People's Advisory Panel, which is a new panel that we set up with people with lived experience and carers, and we're presenting it to yourselves as well to get feedback on, does this reflect your experience of adult services, working with us, and any feedback that you would like to give us. And also, as part of the inspection process, CQC will be linking up and contacting with our partners as well.
Thank you very much. It was a very brief but precise and comprehensive presentation, nicely structured. So let's see whether there are any questions to Sarah. Yes, please, Jeff.
First of all, what an excellent presentation. Precise, short, clear, mixed change. Sometimes we get so complicated we can't actually keep up with it. So thank you very much for that. One thing that, if I was to say about our service that worries me sometimes, as I'm sure is worrying everybody else throughout the country, is our staff shortages, our unavailability of all the people that we want to meet our requirements. Do you think this is something which is going to show through this survey that's taking place with us? Do you think we'll be knocked back because we don't have the right number of people?
Yes.
Yeah, I mean, really, really good question, Jeff. And I mean, it's obviously it's gone in as one of the risk areas for us, and I can't imagine it hasn't gone in every other local authority's LASER across the country at this point in time. I think what we will be able to show when we speak to CQC, and what we have demonstrated in what we've submitted to them last Friday, is a strong trajectory in terms of trying to manage that problem. I mean, I think you'll be aware from some of the briefings that Cabinet have had. 18 months ago, we had 270 people in Northumberland who needed domiciliary care that we couldn't supply that for immediately at that point in time. As of last week, that number was down to 35. And that follows an incredible amount of work with the different sectors and with the providers in terms of wage increases, mileage rate increases for staff, we work with providers to assist them to kind of improve their recruitment processes and things like that, look at staff retention and how they're operating their cultures around that. And we've clearly made inroads with that, as part of it. I don't think any local authority could quite put its hand on its heart at the minute and say it's completely solved that problem, but I think we can show a good direction of travel. And I'm hopeful CQC will be appreciative of that when they come in. But this is not a problem that's going away. I mean, we've still got an ageing population. We know overseas workers at the minute is part of the solution as well. And most areas have seen a large influx of overseas workers, which has brought some of its own problems as well in terms of the management of that, some of which have been well publicised in the press. But I think we've got a good story to tell when they come in at the minute, but we're not out of the water with it.
Can I just come back? You're right, I was aware in the Cabinet that we were trying all sorts of things, taking your lead of how we could sort it. And I knew a couple of, some time ago it was 270. What I didn't know was that it was down to 35. And that's great. That is really good news. So thank you for letting us know.
Yes.
Yeah. The theme and nearly everything that we're doing this morning, I think, is around our ageing demographic. We'll pick this up as we go, but it really is highlighted to me today. You've mentioned, I think, a strength-based approach as a risk. And I'm just curious to understand the thinking behind that, why that's in there as a risk. I'm not saying it shouldn't be, but I just would like to know what you're thinking.
Yeah, so I mean, just in context, because it's a kind of a throwaway trendy term, isn't it, strength-based approach. So what we're particularly focusing on there is around the interaction between social workers and care managers and clients when they first start to interact at the point somebody approaches us. And I think too many authorities, and I've worked in a number of different authorities, and we've been caught in the trap as well of, we try to solve problems with individuals. So they come in and our immediate fix is to offer care, to offer a solution. The idea of strength-based approaches, that's not the start of your conversation. The start of your conversation is what's working well in your life at the minute, and what do you want to develop, and what do you want to strengthen in that part of your life to give you a good outcome, based on the circumstances that are facing you at that point in time, whether it's disability, whether it's ageing, whatever it is. But we focus on what's working well, and we try and build on what's working well, as opposed to focusing on the negativity and trying to fill the gap with the service there. And that's all about enhancing the quality of the outcome for people. Now, that's a route culturally that we've been trying to push within frontline social work teams. They've run training programs on it. But we know at times of pinch point and pressure, when people are dealing with large caseloads and things like that, it takes a little bit longer, and it takes a little bit more thought to go through a strength-based approach with individuals. And that slips at points in time, and we go back into, it's easier to allocate a dollop of domiciliary care or whatever. So what we're saying is if CQC come in and test now, I think they'll find some good evidence of strength-based approach, but it won't be universal across everything we're doing. And we're trying to make that more universal so we know that's still a direction of travel for us.
Any other? Sherry, please.
Thank you. Thank you for the presentation. It's just a comment that there's an awful lot to be proud of within the presentation and the paper that's attached within the notes, particularly encouraging around the engagement with stakeholders, and I'm really heartened around the engagement with our mental health services. A curiosity around one of the areas of development, just for learning for our organisation, what specifically meant around technology, please?
So we're continually looking at what, for example, assistive technology might be available to us that we can utilise. We're part of various different regional and national groups looking at technology. The regional group that we're part of, each different area is piloting a different technology to then feed back. And we're just continually looking at something that can support in the various different facets of adult services. But assistive technology definitely is one of the key areas that we're looking at.
I mean, I was going to say, Sherry, just as a couple of examples, I mean, we have just engaged Mobilise in a project with a web-based solution to try and spot carers that haven't presented to us already. So they're operating out there in the system, perhaps struggling along and things like that, and trying to get that first interface sorted. And we are piloting, every local authority across the region is using some government grant to pilot a different sort of assistive technology, and we're all going to share the outcomes. And we're having a look at an Amazon-style product, but through a wall-mounted telly, for communications with people, potentially to do medical prompts and things like that, to attack loneliness and lack of interaction, so it'd be the equivalent of a simplified TV-mounted FaceTime. What I have to say is we tend to be quite pragmatic in Northumberland. I think some local authorities across the country are quite evangelical about assistive technology. There isn't always a strong evidence base for the benefits of that. And I think with limited funds and limited resources, we're just being a little bit more careful that where we do target something, there really is a strong evidence base that the clients are going to get something significant in terms of value out of it, or we're going to get something significant in terms of value and efficiency from our side in operation as well. So we're naturally cautious and possibly more sceptical than some, because we just want to invest every pound quite well in it. But there's a raft of things going on across the region as well that we're just monitoring and watching. And I'm happy to share the feedback, obviously, between organisations. Yeah.
Any other questions on that report? May I ask one question? I think you put direct payments as one of the key challenges and risk, this one. So when I'm looking at the key headlines, that is the one and only 17 report outturns where Northumberland is, scoring really bad. And you put it on, you highlight it on the red, worse than the Northeast and England averages. So what is our plan to, when we talk to CQC, how we are going to tackle this? What is the root cause of this, if we could enlighten us if possible?
Yeah, thanks, Paul. I mean, direct payments we are particularly low on here in Northumberland, and there is a very specific reason why we're lower than the Northeast region and some of the others, which is the government was very excited about direct payments for almost a decade, from the mid-noughties through to about 2015, 2016, and then it dropped down the national radar a little bit. And what I would say very openly, because I've said it in other forums, is local authorities were under a lot of pressure to get those numbers right up, and there were some odd games that went on to get those numbers up, which to me were never really the true spirit of direct payments. So many authorities, and we used to do this, would give a direct payment out to allow you to buy domiciliary care from a normal domiciliary care provider. Now, bureaucratically, that's incredibly inefficient because we're contracting with them anyway. Yeah. So you have to set up a whole process to hand the direct payment over, to audit that it's being used effectively, to potentially reclaim money if it's not used effectively, for something that in a loop we could have done just through an invoice and a payment from the local authority. Other authorities, every time they hand a piece of equipment out, they give a direct payment for the person to effectively buy the piece of equipment. We don't do that. We just give the equipment out. It's quicker, it's easier, it's less bureaucratic. It gets the same outcome. So we don't, I mean, what I would very overtly say is we don't game the system necessarily as much as everybody else. But I understand why everybody felt pressure to do that, and we did at points in time as well. But when the government backed off direct payments about 6 or 7 years ago, we backed off. It's become more popular as an issue again now, and I think rightly so, because it's about empowering people to take control of their own lives, to take control of their care, etc. And what I want to do is grow direct payments in Northumberland, but in the right areas for the right people who genuinely want to take control. They want to employ their own personal assistants, their own carers and things like that, and they want the control to be able to choose that and not go through an agency. What we do know is when you look comparatively between the rest of the country and the North East, our numbers are low across the board. So it isn't just Northumberland. Ours are particularly low in Northumberland because we don't do the handed over for home dom care and things like that, but they're low everywhere. There is a hypothesis, and it's unproven, that perhaps the North East isn't as enthusiastic generally as a population about taking control. I mean, I worked for a period in Oxfordshire and Reading, you know, and in the Thames Valley area, people were much keener generally and culturally to take control of money, to take control of their lives, etc., and what was going on. There's possibly more of a dependency culture up here in the North East, but that's a hypothesis of mine. That's not proven, but we are looking at that and trying to investigate it because there's clearly something going on in this area. What we're doing is we've got a project. We've had a project running for 9 months. We are training our frontline staff. We're looking at the information and support we give around direct payments. And what we're trying to do is make it as easy as possible for people to use direct payments if they want to here. But at the end of the day, we can't force them, and I wouldn't want to force them. So I think this will be a slow process. When CQC come in, we've got a project. We've got a direction of travel. We've got a story we can tell. We're definitely not at an end game for it, though, in terms of what I think the government envisages is people taking control of their lives.
Thank you,
Yeah.
because that's the only thing.
I think it's just general feedback. So I think it's a really comprehensive document which outlines the strengths and risks and challenges. And I think one of the key things for inspection is to know yourselves well and areas where you improve, and I think that demonstrates that very well. I think that the one question I have is then about evaluating progress, and you said like quarterly updates. Now this is there's loads of work going on there. So I suppose my question is just about the systematic approach for updating and evaluating the kind of plans that are coming out of this.
Yeah, I mean, we have a lot of individual action plans, and we do have a robust loop now, which actually is managed through Sarah's team. So Sarah's team was created when we separated from Northumbria Acute Trust, because obviously we were embedded in their governance system. We've created a system to make sure that we loop round and we capture. Action plans are followed through, we update, we review, back through the management team, etc. The LASER in itself is one we're going to have to be very careful about, because clearly the whole purpose of this LASER was building up to an inspection. And we had plans to quarterly review that in the run-up to the inspection. Of course, the inspection is going to happen now at some point in the next 6 months, and the LASER has already been submitted to CQC. But we know inspection isn't going to stop here. It's going to loop round again in a cycle. So we plan on keeping that quarterly review so that we don't end up chasing our tails in 2 years' time, 3 years' time, the next time the cycle loops round. So yes, it's timetabled into the work that we're looking to do. We have a governance team overseeing that group.
Just on that as well, Graham, we have updated the LASER, the version that was actually circulated with the papers, which I will send out and can be reshared with everyone. So that's how frequently we're trying to make sure that we update it to keep it as accurate as possible.
You, Sarah and Neil, thank you. And we move on to the next item. Transport Health Needs Assessment will be presented by Kat Marinussen, and it will be introduced by Veronica Jones.
Hello, thank you. I'm really pleased to introduce this one. The lack of access to transport is acknowledged as an inequality in the health and wellbeing strategy. And particularly lack of access to transport for jobs and social connections. Good transport is one of the building blocks in the health and wellbeing strategy as one of the building blocks of a good life. This report is about the availability of public and commuter transport across Northumberland, and it identifies where the gaps are. It's a very impressive report. The report recommends that health and wellbeing endorses the recommendations and embeds them into health and wellbeing strategy. I wanted to say it's a really impressive piece of work. So if you're ready, if you're not, don't worry. I'll hand over to Kat Marianson, who's going to take us through it.
Thank you so much. Thanks for the introduction. I'll just wait for my slides to pop up. anyway, I'll start with my little preamble first anyway before the slides come up. So thank you very much for allowing me to present today. And also thank you to everyone who was involved in pulling this together. It was a really sort of across different teams, both within the council, worked with lots of healthcare partners, lots of partners in the voluntary sector. So it was really kind of multidisciplinary piece of work, and hopefully that's one of its strengths. Try to draw on lots of different areas of expertise. So if I just take you through. Thank you. Right, lovely. So a little bit of context about what a health needs assessment actually is. So put simply, it's looking at population needs, which in this case we did through drawing together routine data and also bringing in community voice through focus groups, and I'll talk about that in a little bit more detail. So looking at what the population needs are, what the current provision is, and then where the gap is in the middle, and how we can then address that gap going forward. A couple of definitions. So we define public transport as theoretically available to all, and theoretically in brackets because, as we'll see in some of the key findings, in practice there are demographics of people who may struggle to use public transport in its current form. It runs along fixed routes and it charges fares. Community transport tends to be community-led, as the name would suggest, and also tends to have a wider aim than just moving people from A to B. So there tends to be often an element of befriending, of social support, and that can be invaluable as well, and a core part of that. And some examples can include things like volunteer driver schemes, dial-a-ride schemes, or patient transport. And this work grew from inequalities and the inequalities plan. So health inequalities, or rather inequities, just to kind of remind everyone, it's around unfair and avoidable differences in people's access and outcomes as well. So it's a health needs assessment, and we defined health across three key areas, which was access to healthcare services. So that includes perhaps more local services like pharmacies and general practices, and also larger hospital centres. Economic health, and this is both in terms of how transport can support employment, education opportunities, but also the impacts of the cost of transport on a household finances. And finally, social health, so connection to family, friends, leisure opportunities, these opportunities to unwind that we also know that keeps us healthy and stops people from feeling lonely and socially isolated, which can have significant mental and physical health impacts. So why transport? As I mentioned before, this grew from the work around the inequalities plan, and this graphic here is called the Place Standard tool, which was used a lot in developing the inequalities plan, which approached local residents and asked them to rate these different areas of their community. So this is actually an example from Berwick, and you can see the red kind of spider web is the county-wide average, and the blue is the local rating, and public transport, which is kind of the 1 o'clock position there, scores lower in the Berwick area. And this also helped guide the focus of the report. So it's a county-wide recommendations, but we tried to go into more depth in the north and the west, because we know that the rurality of these areas and the sparsity of population can make transport an extra challenge. So how did we pull this together? We used three key forms of data. So the first was kind of looking at the literature. What do we currently know about transport and health? What's working well in areas, or what has been shown to not work? Routine data, and that informed a lot of our mapping, which I'll show in a couple of slides. And then a big part of this was the community voice and the focus groups. So we tried to reach out to lots of different groups to hear more from them about what they feel is missing and what they would like to see, and drawing these three together. Within those focus groups, again, we wanted to keep a keen eye on inequalities and knowing that people have different needs. So we specifically focused on what are known as the 4 domains of inequality. So that's geography. So I've mentioned the focus on the north and the west. Socioeconomic status, protected characteristics. So that's things like people's age, or we know that people who have a disability are more likely to rely on public transport, so reaching out to those groups to see what their needs are. And then those with, in this case, we focus on people with high healthcare needs, as again, we know that they are more likely to rely on public and community transport. So again, a little bit of general context about the way travel has changed. So this graphic shows local bus service use, and you can see the kind of the steep drop-off in the 2020-21, which was as a result of the coronavirus pandemic. But even before that, you can see that general usage was declining. And as we've seen patronage pick back up after COVID, it's still below where we were pre-COVID levels. And I know that's a significant challenge for our transport team as well. So these graphs are some of the mapping that we did. So the dark black lines are the current bus network, and there's some grey lines which show the rail network as well. And we overlaid these on several maps to highlight where some of the issues might be. So this first one is looking at areas of deprivation. And the darker the purple, the higher the deprivation is in that area. So some areas which have higher deprivation and therefore perhaps more people may not be able to have access to a private vehicle or afford to run a private vehicle and be more reliant on public transport. In some of those areas, there's a dense cluster of public transport networks, but you can see that in some of the rural areas, actually, we've got some areas of higher deprivation where the transport links seem to be a bit more sparse. And another view of that is looking at the percent of households who don't have access to a vehicle. So again, the darker the colour, the higher percentage of households that don't have access to a private van or a private car. And you can again see that in the north and the west there are some areas where actually a higher percentage of households may be fully reliant on public transport, but actually the links are quite sparse. Something else we looked into is the potential fragility of the networks that we do have. So this is just showing the routes that are and are not supported by us as a local council. So all the green lines are currently supported, and the red are sort of independently, purely commercially run, as it were. So you can see that in those in the southeast corner where there's more of a dense urban network, a lot more services are able to run purely commercially because they have the footfall, whereas a lot of our network is having to be financially supported, and obviously in times of strained resources, that introduces a significant element of fragility. Just because a service is there doesn't necessarily indicate, how there it is, as it were. So these just break down some of the frequencies. So in terms of evening services, we can see that coastal route and that main artery out to the west does have evening services, but a lot of our more rural areas don't. And we know that can impact both on those leisure opportunities, accessing evening economies, but also employment. So healthcare is a large employer, hospitality is a large employer in our county, and those shifts tend to fall outside of the 9 to 5. So not being able to get a bus after, in the evening can impact your ability to get to and from work. And then finally, this is looking at the frequency of services. So I've just broken it down into a little bit more manageable, but again, you can see that the really frequent services tend to be clustered in certain areas, and the more rural areas have far more infrequent services, and that can impact on your travel time and your ability to make onward connections and so on. We also mapped the community transport, not all of them, because there's so many fantastic organisations that are undertaking community transport, but just the larger organisations. And again, we know that most of these organisations operate county-wide, but trying to map where 3/4 of their work takes place to show a bit more accurately where their day-to-day reach is. So you can see that we actually have a really good coverage of the county currently. What this perhaps doesn't highlight, which hopefully in the report we go into a bit more detail, is the diminishing capacity of a lot of those providers. So we know that costs have increased for them, costs of buying fleet, maintaining fleet. So even though they have this reach, as the demand increases, it can be more difficult to cater to that. And these following themes are as a result of the focus groups that we did. So none of them, I think, will be surprising, but is probably just a good summary and to focus our recommendations going forward. So the first is reliability, so people are wanting reliable services. For public transport, this was often around cancellations, of buses, for example. For community transport, this was a lot around that element of sustainability that I talked about before, and as costs increase, how able are we to sustain the service? Reach probably speaks for itself, so we know the network has shrunk over the past few years, and just ensuring that people are picked up where they need to be picked up from and where they get to where they need to go. For community transport, which tends to be a lot more flexible, this is also around the fact that there are some demographics who perhaps are not able to use the community transport that's there. So if you're, for example, a working person, you need to get to and from work at 9 to 5 every day, that's a lot of demand for a single community transport provider, so it's unlikely you'll be able to use that service regularly. Flexibility, both in terms of travel time and also in terms of timetabling. So we've already mentioned about the lack of evening services there. Affordability was a significant theme as well. And one of the positives in this is there was a lot of appreciation for the £2 cap fare, which is why that's one of our key recommendations. Also, concessionary passes are seen as really important to allow passengers to travel. Accessibility, there's two icons because this split into two kind of sub-themes, if you will. So the first is around ensuring that passengers with extra needs are supported in that. So, for example, audio announcements in buses are turned on for those who may have some visual impairments, ensuring there's space for wheelchair users or those with buggies. And there's also an element of access to information, both digitally and in physical spaces, ensuring that that's joined up, that that's up to date and accurate. And in those physical spaces is also, a large enough print to be accessible and things like that. And finally, safety, both in terms of personal safety, less so on vehicles itself. We heard more around in train stations or in bus stops, those kind of interim spaces. And I know there's already some work happening within the council, working in the West with the police on looking at antisocial behaviour in those spaces. So that's already on our radar. And also safety in terms of, for community transport providers, that safeguarding element and ensuring that if we're working with vulnerable people, we have all the correct safeguarding in place. So what now? So these are the overarching titles of the recommendations, but I'm going to go into a little bit more depth. So obviously I've come to speak to you today, and looking forward to your questions. This will be embedded into our joint health and wellbeing strategy, and we're also working with partners on a regional level to highlight the rural voice regionally as well. In terms of the specifics, so prioritising transport as a key factor in sustaining good health. For this, we're working with our healthcare partners, and also our recommendation is to work with businesses and employability schemes, as we know that transport's so key to recruitment and retaining employment. As I've mentioned, we're embedding it into the joint health and wellbeing strategy. Ensuring the sustainability of public transport. So we're working closely with public health and transport have been working closely throughout this process, and hopefully will continue to do so, to look at how we can use the rich data that we have to inform decisions and guide how we grow the network. I've mentioned about working with regional colleagues on highlighting rural transport needs regionally, because we know that often rural needs are different from urban needs. Lobbying for the continuation of the £2 cap fare, and also investing in digital platforms for public transport. I know there's plans regionally to build a robust online platform, so feeding our data into that. Looking at the sustainability of community transport, so we heard a lot about the strain that short-term funding cycles can place on providers, so looking at the, making funding more long-term and perhaps less focused on innovation and more on sustainability and success, and a close collaboration between ourselves and VCS to support them. And then finally, supporting those at the highest risk of transport-related exclusion. So having that place-based approach, realising that passengers in, in the north are going to have different needs from passengers who live more centrally and so on, and tailoring where possible to those needs. Increasing the awareness of concessionary passes. Where they were used, they were really appreciated, but I think a lot of people were not aware that it was potentially available to them. And also ensuring those accessibility quick wins, some of which I've mentioned, around turning on audio announcements on buses, ensuring drivers are trained and feel able to manage passengers to help passengers with extra needs, and having clear timetables both online and in physical spaces. So that was a whistle-stop tour. So thank you very much, and happy to take any questions or comments.
Oh, thank you very much, Kat. It was another wonderful presentation with lots of pictures and crisp explanations that accompanied them. In fact, I always had a self-doubt when it comes to the difference between equity and equality. Your picture settled it once and for all. So thank you very much. Are there any questions for Kat? I wish so. Yes, please, Sam. Yeah.
So, going through that presentation, from a recent point of view, and I probably asked whether we're going to have access to that. So, and we need to consider that when we're thinking about partnership communication strategy or engagement strategy, because I need to be mindful, for although this was about public health, those communities that can't access transport will need a very different engagement opportunity to tap into policing and other partnership provision. So excellent bit of work, but can I please have as a presentation as well that I can take away, so that make sure that we are linking in with that when we're looking at our Northumberland, particularly our rural access to police provision.
Yeah, absolutely, and thank you. I mean, as I say, I'm here from public health, but if there's one takeaway I'd love for the presentation to have, it's that this impacts all of the different sectors, so policing, healthcare, employment. It really is, it's very broad. So yeah, absolutely happy to send it to you.
Thank you. Yes, please.
I'm just not sure where you start and where you finish with when you start looking at something like this. You haven't mentioned air quality, and I'm thinking about public transport, buses, electric vehicles, that side of things and its impact. We have lots of fresh air in Northumberland, but I suspect there are some pockets of our towns where it's not so fresh, and that might have an impact, and we tend to just ignore that a little bit, perhaps. And we haven't got anything about rail on here either. And I probably just didn't quite fit the remit and the rurality and things, and car transport as well. So it all has an impact. So where does that merge with what you've got to so far?
Yeah, thank you. No, as you say, it was quite a broad area of work. So as part of trying to keep it manageable, there were unfortunately some areas we couldn't touch on, air quality being one of them. So in the report we do, obviously, as you say, there is an impact of that, but we weren't able to go into that in more depth. The same with things like active travel. So we know that using public transport means people are more active generally. Weren't really able to go into that in much depth. And then your other point, so you were talking about the rail. Yes, so the railing is included on the mapping, and in the full report we talk a little bit about future plans, like for example for the Northumberland line. I think just because we were focused on the north and the west, and then as you mentioned, the rail networks there are sparse if or non-existent, so it didn't come up so much in focus groups and things like that, but we've acknowledged the Northumberland line and things like that are going to be developed. Mm-hmm. Thank you.
Yes, Glenn, please.
Glenn Sanderson. I just think this is a good report. First time I read it, I was really interested and very disappointed to see that the opportunities for getting a job are more likely if you have a car rather than riding on public transport. That is a really important point for us to remember. I think, though, looking slightly longer term, I feel very positive about the fact that we will see change and improvement in public transport. You've touched on very briefly the Northumberland line. That's going to have a massive effect in offering alternative ways to get in and out of Newcastle and back. But actually, the new combined authority will have greater powers and much more money. And so what we need to do, and it really ought to be in here, I think, when you're talking about actions for us to take, we need to make sure that our lobbying within the new North East Combined Authority is such that all of this money, and it's hundreds of millions, will be spent in rural areas just as much as it is in urban areas. And so it's up to us, actually, to make sure that we do that and have that strong voice. And I think we will have. So I think it's a really important piece of work, this. I think in terms of the work that we're doing with around inequalities and also around jobs and business. And so I'm grateful for you to have done this, and let's just keep the focus on it. So it would be actually quite good to have some kind of a follow-up summary on what might have changed. Maybe 6 months is too soon, but I would like to see something coming back to the Health and Wellbeing Board, if we could, Chairman, in due course, but certainly within 12 months, if that's acceptable.
We will do that, definitely. I think this is a very thought-provoking, in fact, exercise, Kat, actually, because I very often use public transport, go to work from Cramlington, but of course I can't talk about community transport because I live in Cramlington, so the public transport is wonderful. However, I often come across lots of things, simple things, like timetables, bus timetables not there properly. Sometimes the bus stops need to be looked after. Very recently I found out the gully in front of the bus stop is blocked. So water is stagnant. So every time the bus comes, it splashes water into the bus stop. So there are so many small things we can do as a council. I agree with you. And also big things like I use Arriva app, that's fine, I can find out. But for people who are not digitally informed, they will find it difficult how long I should wait for the bus. Some kind of interactive session or something should be put in. It requires an infrastructure investment, big infrastructure investment. I think we should be pursuing that with the combined authority once it takes shape. This should be a big priority for us. So I take up your suggestion. We will work through a summary, extract what are the things we can do and what are the things we expect combined authority to do. Is that okay?
Can I just pick up the point you've made, actually, because I'm not absolutely sure where the responsibilities lie around making sure that bus timetables are up to date or that bus timetables are visible or legible even. So do we know that? Is it our responsibility or is it the bus companies?
Town councils.
The bus companies?
No, bus companies supply.
But what happens in the more rural towns where there is a bus stop? Whose responsibility is it to make sure? It may seem like a silly point, but actually it's really quite important.
It's not the parish council.
It's not the parish council.
Not the parish council.
It's not the parish council.
Parish council, sorry, parish councils in my area do not.
Is that bus companies produce timetables, they give it to the parish council, and they go and put this one. They don't generate. They can't generate, actually. They don't do that? That's what we do in Cramlington.
Oh.
Yeah, Veronica, yes.
I think responsibility is probably the wrong word. I do think the bus companies do have arrangements with town and parish councils. I know at least one of my parish councils does have that arrangement, but I think it's an arrangement rather than a responsibility.
Oh, I see.
What they do where it isn't picked up, I'm honestly not sure.
Okay. It's nice to have Veronica with all the experience and wisdom.
I'm really sorry, can I come back again? Because I'm quite
sure.
confused now, because I don't know whether this is part of the council's responsibility, the folk that work in the bus and the public transport section, to make sure that bus timetables are legible and are there and in one piece. If it is our responsibility, are we happy that we are doing it across the county?
I think it's something we should look into, and I think we should take it away from this meeting and sort it out. Yeah.
That is the outcome I'm looking for, actually, to look into who is responsible, how we can provide these services. Yeah.
would
Yes,
we
please,
find out?
Jill. Yeah.
It's not to add to that point, because I do think we need to take it away if we're clearly unsure. It was more to ask the board whether or not we feel that there is relevance and purpose for the board to write to the incoming combined authority in relation to this board paper and highlight from a health and wellbeing board perspective just how important we want it to be, and therefore what is it that is in our gift and responsibility at Northumberland level, but actually what key points would we like to have a voice around the table at Transport North East as it evolves into combined authority. So it's whether as a board we write formally and request presentation of this report.
Thank you, Jill. That I think you captured what was in my mind thoughts. Thank you very much. Does that satisfy you?
It does, and I think actually what I would go as far as to say is that it would be very useful to send a short side of A4 bullet point summary. I know it's hard putting all these pages into one, for the leaders of and the portfolio holders of the combined authority in advance of when it starts in May. So, you know, in the next month or so, I think literally a side of A4 with some bullet points highlighting the need for attention and money into rural areas in particular. And I would also like, I think that would be really good. So the paper as a whole to go to Henry Kippen, but a brief summary to all the leaders.
Yeah, thank you very much, Glenn. Thank you. It's taken. Yeah. Any other questions? No? Thank you. So thank you very much, Kat. Quite a lot of discussion. That's also good. Now we move on to Public Health, Director of Public Health's report, and I think that will be presented by Luke Robertshaw. Mr. Luke Robertshaw, thank you, welcome. And that will be introduced by Veronica Jones as well. Sorry.
Chair. So this is the Aging Well report. So I'm not going to say very much on this one because it is within the public health portfolio, but it is also an independent report from the Director of Public Health. So it's a statutory report as part of their professional role as the DPH, and it's with the subjects of their own choosing. So because of that, I'm really, as you can imagine, delighted that the subject that Jill has chosen in her first year here is on ageing well. So I'm just going to say that and hand it over to Jill, who's going to actually introduce the report.
Thank you, Chair. So yeah, this is a bit of a tag team approach. I'm a firm believer that those who do the hard yards of the work deserve the glory, which is why I'm asking Luke to present the report today, because he was primary author and coordinator. So huge thank you to all that have contributed. As Veronica states, this is my first formal statutory requirement to produce a DPH annual report. And I just want to highlight the fact that this it doesn't warrant an action plan. It isn't about having a set of actions thereafter. They are an opportunity to create a commentary and a state of the nation of a subject of my choosing. And when I first came over to Northumberland and I was reviewing what was worthy to note and comment on in relation to the public's health, and it was about looking at the demography of ourselves in Northumberland, clearly, as you can imagine, what stands out is that we are an outlier in relation to our ageing population across the North East, but actually that is often seen as a negative. And I really wanted to shift that curve and shift that narrative quite strongly, because actually we've got so much to offer in relation to having an ageing population. Bearing in mind, as soon as we are born, we are indeed ageing. And a lot of people end up focusing on the frailty side towards ageing, but this is about more like midlife really, and into getting older as opposed to the frail elderly aspect. You will also note from the report, it doesn't focus on illness per se. There isn't specifics around dementia or cancer or cardiovascular disease. Again, this is about ageing well and what the functions and components are for us to be able to have good health in our long life as opposed to just long life in ill health. So that's what Luke is going to focus through. It is longer than some other DPH reports that you might be familiar with over previous years, and that was because of, in the absence of having an older people's strategy, or because of what I've just said, people focus more towards the frailty end and the medical aspect of ageing. We wanted this to be a repository of information where some high-level stats were shared with you on the population demographic, but what's the evidence base tell us on how we can age well? We will have and do have a cliff edge, which I'm sure Neil would talk long about, that if we don't function, if we don't focus on the functions of ageing well, we will not meet future demand in relation to health and social care. So this is an absolute must. So whilst it is a state of the nation, the call to action is adhere to these recommendations and take these back into your organisations to think about how we do prevention and early intervention to maintain well-being, because that is the golden ticket to manage finite resources going forward. So I'll hand over to Luke. Thank you.
Well, thank you very much, Chair. Thank you, Councillor Veronica Jones, and thank you, Jill. So I guess if there's one thing that we all have in common today is that we're all getting older. And it's one of the few things we can be certain of in life, and there aren't too many of those. And I think I'm personally reminded of it every time I go for a haircut. Every time I think there's a few more grey hairs there. And that reminds me that, you know, like everyone else, we're all on that journey, we're all aging. But what does it really mean to age well? What influences our experience of aging well as we go down that journey? And what can we do to support individuals and the population as a whole to age well? And I guess they're the kind of key questions that this report really focuses on. And you'll have a copy there on your tables. And we are really delighted to present this report. And as Jill said, I think this strengths-based approach to ageing well is a really groundbreaking feature. I have seen other DPH reports on this topic elsewhere, but I haven't seen any with quite this focus. So Public Health, we led on the development of the report as it's Jill's annual report, but what I wanted to emphasise is this has had really good input from others outside of our own area, so across other parts of the council, across adult social care, across the VCS sector as well, and other stakeholders. And I think that really reflects the fact that supporting people to age well is something that we have to do together as a system. And it's something we have to do across all of society, and it's everybody's business essentially. It's not down to one agency or one role to do that. So we'll move on to some of the, the first slide actually is just to make the point that this is Jill's annual report. The local authority has a duty to publish a DPH report every year, and every year it's really our own choice to pick a topic that we feel is particularly pertinent for this time. And as Jill said, ageing well is something we really feel should be picked up at this time. So, why is ageing well important, and why should we be focusing on it now? And this first slide really emphasises the point that Northumberland has a particularly ageing population in comparison to other areas, and particularly when you look at other areas of the northeast. So this chart, the orange bar on there is the Northumberland 55 plus population, and the other blue bars are the other local authorities in the area. And you can see that we have a significantly higher older demographic in our local authority area. Oh, wrong way. This next slide really looks at what's happening as we move forward in time. So Northumberland, not only do we have the oldest population in the area, but this is set to actually get older over the next 10 years. So it's really over the next 10 years that we're going to see that shift happen to the older demographic, and then it will probably level out. This is what the projections tell us. So that green line there is a 65 plus population, which you can see going up, and the other younger age groups are kind of going down slightly. So the balance is moving. And as has been said already, that's something we really need to face and adapt to, and think about how we're going to change or operate differently in that way. And I think, you know, what's been said already about really boosting health is really key to that. So that prevention story. And then the other key thing about why it's important is the real variation that people experience in aging. And we see quite stark inequalities between different parts of the population. So this is for men, this graph here, and the top bar is the life expectancy in the least deprived areas, so the places where there's potentially more wealth in those areas. And the total length of that bar is the life expectancy, and we can see that that goes up to 91 in the least deprived areas of the county. And then the bar underneath is the most deprived areas. And the total length of that bar is 72 years. So it's actually almost, well, it's around 18 years overall, the life expectancy difference, which really focuses the mind in terms of how the inequalities really manifest themselves in older age. The kind of yellowy bar within that is healthy life expectancy. And that really describes the age that people get to in a good state of health. And it more gives that idea of quality of life as well as quantity. And we can see that people in the most deprived areas get to just over 50 years old in good health. And obviously that's going to cause a lot of friction with working and being able to contribute to the economy as well. And then we see a very similar picture among females as well. So this report has structured itself around these 5 functions of well-being, which come from the World Health Organization. And as we've said, this is really about taking a positive strengths-based approach. So all these are about functions that people do rather than what they can't do. So it's not about decline, disease, or being a drain on society or deficit. It's about meeting basic needs, being mobile, contributing to society, building and maintaining relationships, and learning, growing, and making decisions. And I think this is really a holistic way of looking at it and emphasizes the strength-based working rather than that deficits model. So each of these areas, the report basically expands on these, and there's a number of topics within each area. And we've said this is quite a long report, so I think the real strength of the report is that it really touches what are the key bases we need to think about in these areas, rather than drilling down into a huge amount of detail. So each of these sub-areas could be a report in themselves, but then we'd end up with the Oxford Dictionary here, not this still pretty chunky document. So meeting basic needs includes things such as good housing, healthy diet and nutrition, financial well-being, staying healthy for longer, and health and social care when needed. So just to give a bit of an example of the way the report structures things, each of these sections does a very high-level summary of why the issue is important for older people, and then gives some examples of what we're doing in Northumberland and some of the ideas and ways we could potentially move forward or do things a bit differently in the future. So again, it's examples, it's not everything. There's loads more happening out there that's not captured within this report. So for financial well-being, for example, obviously it touches on why that's really important for older adults. Things such as accessing benefits that are available to them, some of the vulnerabilities that are there to scams and things like that. But then it also looks at what we're doing across Northumberland to support financial well-being in older adults. So we have a financial well-being network which is really trying to take a comprehensive all-round look at how we can support financial well-being among the population. We also have some initiatives such as Barclays Bank, who are setting up kind of pop-up banks in community venues across the county where they don't have access to traditional high street banks. And then we also include the example of the Northumberland Community Bank, who offer very small-scale loans to people that provide much less risk for them as individuals, so they don't have to take on such big levels of debt, but also encourages people to save. So that's a bit more of an example of the kind of detail it goes into in the report. Being mobile covers obviously physical activity, maintaining strength and balance, which are really important to maintain health and well-being going forwards. And I think linked to this, the work that's going on with the procurement of the new leisure contract, which really puts improving physical activity across the whole population in focus in that new contract, but also addressing the inequalities that we see and making sure it reaches to particular demographic groups such as older adults. We've talked about access to transport, I won't say too much about that. And then obviously the way places are built and designed influences people's experience, particularly in older age. The next section on building and maintaining relationships covers these areas of social participation, strengthening relationships, sexual health and intimate relationships, and domestic safety. And just thinking about social isolation, it's been found from research evidence that social isolation can be as harmful for people as some of the other public health risks that we often think about, like smoking or physical inactivity or overweight. So it is a really important issue. Learning, growing and making decisions. This is all about helping people maintain that sense of control and independence in their lives. So making sure people have the opportunity to grow and to use their minds and to keep exercising their brains, and also having the access to the information, advice, and that people are included digitally. The final section within the report looks at contributing to society, and just to pull out in this one about the volunteering section. So we know that volunteering is obviously really good for supporting society as a whole. It's also really good for the person who volunteers for their own mental well-being and having that sense of purpose and contribution. And there's a number of initiatives going on across the county to support volunteering. So Thriving Together run a programme where they seek to support volunteering and link people up with different groups where they can do that. And there's currently a new volunteer passport in development, and this is being funded by the ICB, but it's being managed through Thriving Together. And it will be a digital platform that people sign up to, and as they begin to volunteer, they get onto that system. And then if they want to move to volunteer in a different organisation, they don't have to go through all those checks and DBS checks and everything again. They're a trusted volunteer who can then move around between different volunteering opportunities. So that's something that's in development and I think could really help enable more to happen in the future. So just moving on to some of the recommendations, if I can get this clicker right. As I've said, really continuing to have this positive strengths-based narrative in contrast to some of the negative ways that ageing's been viewed in the past. Acknowledging the significant variations in experience that older adults have, and people's experience in older ages is strongly shaped by the advantages and disadvantages that people face through life, and they tend to build up and then manifest in quite large inequalities in older age. And then finally that person-centred framework that we've touched on. I think these key bases that we've looked at are quite easy for individuals to relate to as well, about being mobile, meeting basic needs, building relationships. They're quite, I think, easy for your everyday person to see how that really improves their life. So key recommendations, yes, continue with the strengths-based narrative, continuing to embed ageing well in all areas of work. And as Jill said, we're not planning on starting a whole new strand of work around ageing well, but as I've said earlier, it's everybody's business. So we'll look at how the outputs of this report can be embedded into existing work streams and action plans. And things such as tools such as integrated impact assessments that are being developed can really consider the impact of new programs or projects on older adults. We want to continue supporting and promoting the Ageing Well Network. So there's a group of over 200 people who meet regularly and share information and support one another in the work they do to support older adults across the county. And it's great we've got a new VCS lead for the Ageing Well Network, which is Age UK. So they're now leading and administrating this network. We will continue to monitor available data. So there's a huge amount of data and information that's being captured within this report, and I think some of these can be continue to be tracked over time. And I think an important part of that is really listening to the voices of older adults. We were really pleased as part of developing the report to go out and listen to the experiences of older adults, and we've included quite a lot of quotes and bits of information from people that we spoke to within the report, but keeping our ears really tuned into the voice of older adults. Continuing the approach of asset-based community development that we're working on across everything we do. So making sure we harness and build on the strengths of local communities rather than disempowering them. So then finally, there's 3 areas of the report that we felt stood out for further focus. So making sure ageist attitudes and behaviours are challenged. So ageism is a really pervasive form of discrimination that's often not as acknowledged as others, but it's something that all organisations, individuals, networks need to think about how we can ensure that ageism doesn't play a part in what we're doing. We think there could be more done to increase the awareness in older adults to maintain strength and balance. So I think generally people are aware that physical activity is good for you, but I think the idea of building strength, particularly in the middle and older ages, is really important. I think it's less known about, so we're thinking about ways we can raise the profile of that. Then the last one is about social isolation, and it links in a lot to what Kat talked about in her last report about making sure people are well connected, both through transport but also digital opportunities, so that people can connect to people, places and services that they need. So that's the end of the presentation. There's a huge amount to digest, I'm sure, and as you're probably thinking about lunch, I'm starting to think about digesting. So that's the end of the report, but happy to take any questions and we'll answer them between us.
Thank you very much, Luke. It was very good. Nice report as well. Questions, starting with Vice Chair Graham.
I'll go first. So as a resident and a professional in Northumberland, I think I should declare a conflict of interest in everything that, and probably we all should who live or work in Northumberland, because we are all ageing and this applies to our life. As a GP who's worked for more than 20 years now, this is my cohort of peers, it's my cohort of patients who are following me, and it's interesting when I see the demographic about that growth in the population. As a health professional, my immediate reaction is that it fills me with dread, because I see more cancer, I see more complex patients, I see more prescribing, I just, and I think Jill's point about us trying to flip our thinking, one way of looking at it is, what on earth do we do with all that wisdom? So there may be things that we should actually see as positives in this, not just from the point of view as there's lots of things that we can do to improve and prevent. Actually, how do we take this on board and say, well, if this is how Northumberland is, what are the advantages to us? And I'm not clear, to be perfectly honest. It's not something that I've spent a lot of time thinking about. I'm also curious about the demographic modelling, because if that purely looks at predicted birth rate, current population, predicted death rate, we might be a long way off if we're not accounting for migration of population out and migration of population in. Now, to me, that feels like something that we could have an impact on in terms of, do we want to prevent people leaving? We know that jobs in Northumberland and a good place to live, but do we want to attract other people to come in to live in Northumberland as well? And what would be the optimum? So if we looked at the national stats, actually, if we perceive what we're predicting as bad, what would be achievable if we do some things differently? So it's just been very thought-provoking. Thank you.
Thank you. Any other input? Yes, please.
Thanks. It was a really good report. And just to, I think, reiterate what Graham said, I think being an older person, unfortunately, I don't live in Northumberland, although I do work in Northumberland. It is really refreshing to see that narrative flip from being old as something that's not good to being old, to being that's something positive. I think we need to remember that there's a lot of people who don't manage to get old. And I think just from a health perspective, it's a health service, but what we tend to treat is ill health. And it's sort of, again, I think the challenge is going to be, you know, how do we flip that as well? Because the focus is, in terms of government funding, etc., is always going to be focused on ill health, not promoting sort of good health, although there's obviously some elements of it. But yeah, really good report. Thank you.
Thank you. Yes, Steve.
Thank you. First of all, I just want to say I think it's a fantastic document. It's a fantastic report, and I appreciate, although it's more of a commentary document and it's not necessarily an action plan, this is very useful for us as a reference document within the Fire and Rescue Service, and we will be taking this away and poring over the content to see where we can fit into this and where we can address some of the points that's been raised within it. So I just wanted to say thank you very much. It's an extremely useful document, and we'll definitely be taking full advantage of that within Fire and Rescue. Thank you.
You want to contribute something?
Yeah, thank you, Chair. Yeah, I mean, I would just echo, I mean, I think it's great. We were heavily involved in pulling this together, and it's obviously a subject very close to our hearts in adult social care. The recommendations at the end naturally stay at quite a broad level of themes, which you'd expect in this sort of report, but obviously the exciting bit for me is, does it generate anything in reality? And I just wondered whether there was the possibility, when you loop round to your next DPH report, which will be on a different themed area, whether we could have a summary of what we achieved off the back of this one. Because I know there'll be engagement going on with your team, pushing the likes of myself and other services and things like that. I mean, things like the strength and balance issues and social isolation issues in particular, you kind of just feel there's loads we could do there if we just put a bit of energy into it. And the exponential benefit we'd get over the next decade, 2 decades from that would be amazing, you know, around falls prevention and all sorts of things linked to that. So.
Fine.
Yeah.
Yeah, just to come back to that, what I am familiar with working in other local authorities and producing DPH reports for DPHs is that loop back is quite common actually, and that is something that I am keen to do in subsequent ones. So that will be a new way of working for us in Northumberland. And also live feed, the next DPH report is going to be on moving more, and specifically want to be referencing that relevant recommendation for this report, because physical activity is of such importance that is often a forgotten entity when we absolutely rightly focus on tobacco and alcohol, but actually physical activity, as we know, mental well-being and all kinds of long-term conditions it can impact upon is a ripe topic for us all to have more detail on. So yes to both. And also just to offer, Luke, you might regret me saying this, if anyone wants to have a deeper conversation into their organisations or in other multidisciplinary groups, then we would be really keen to have that discussion, because we've kept this at high level, but then it's back to, Stephen, your point, what's of relevance to you? How can we have that more professional discussion, more nuanced to your particular area to make it of relevance? That we'd be very keen to support that kind of interaction. You're going to Town and Parish Council liaison group, Luke, so we are trying to reach out.
Yeah, I think we are really looking for opportunities to disseminate the report. So definitely keen to do that. But also in terms of the recommendations I put up, we want to systematically go through them and think where are the places we want to speak to for each of those recommendations. So we'll be coming at it from our side as well.
Also impact on the likelihood of being victims of domestic abuse. That theme of isolation, financial vulnerability, not having people to turn to. So actually, from a policing point of view, this is really relevant, and would like to see us exploit more opportunities that we can identify that sort of vulnerability in communities and how these areas impact on that.
I just wanted to say just another couple of things, and I've got to be careful because what I want to say now is probably going to spill over in what I want to say to the next item. But basically, I mean, it's been mentioned here and at other meetings about things like people with dementia and long-term conditions. And by definition, people with long-term health conditions are not ageing well, but they can always age better. And a lot of the things that are in here is to make sure that that's, well, to highlight how that is available, to make sure that they can have a better life. But what I wanted to say, and I think Graham took it from me, was, you know, most of us, not all, I appreciate, live in Northumberland, and age only goes in one direction. So, you know, it's a really important report for us. That's it.
Any other? Thank you very much. So that seventh item, Courtney Partnership and Institute of Health Equity Governance. Veronica, you're going to introduce that as well.
I'll say something now,
Yeah.
Thank you. Yeah, what I wanted to say briefly is to me it is a really exciting step in our inequalities plan. The Institute of Health Equity is the organisation that has professional moment, who set us and many others on the road to regarding our residents, particularly older people, as an asset rather than a liability. You know, that strength-based approach and asset-based approach came from him initially, and I think working closely with him or his organisation through the partnership that Jill's doing is actually really exciting and will actually make us jump further on our inequalities plan. I think it'll just give us that ability to take bigger steps. So I'm really, delighted with this. Cool.
I'm very conscious that you've all been sitting still for the last hour and a half, so I'm not proposing to talk for very long, and a number of you will be familiar with what I'm about to talk about, but we've got a couple of decisions to make as a board based on the governance of what I'm proposing in the slide. So I'll canter through it so that we can open up to the conversation piece. You'll be very familiar, our inequalities plan is focused around people, place and policy. It has been, without doubt, a core mission for us to create that common language and common understanding. And I hear from all different quarters now across Northumberland that we are getting there in relation to that common understanding and approach. And I think that's thanks to everyone in this board who is on message and talking within and deeper into your organisations. I won't go through the detail of this, but just to remind us all that we take an inequalities lens in relation to the work we do, and it is, you've heard it in every presentation, a strength-based approach because of the volume of assets that we have in Northumberland to build upon. But something that is really relevant for all of us is about the voice of residents, equal to data, how we go about commissioning differently to consider inequalities from the start of development of services or implementation of interventions, how our workforce can start to work differently. We heard from Neil before about training in social care, about looking at what's around an individual rather than looking at what's wrong or what's weak in relation to their lives, but also maximising our civic and statutory responsibilities as well. What's in our gift, in our power of our organisations to work as a collective. So that's where we've been over the last 2.5 years, and we want to, as Veronica says, accelerate that now more, and especially in the policy part of the work that we want to undertake. So what we have currently as statutory functions and partnership boards across Northumberland is, obviously, we've got ourselves as a health and wellbeing board. We've been reframing ourselves over the last 12 months with additional and different membership. We've also been working, and it's great, Sam, you're here, and Stephen, we've been updating the Strategic Community Safety Partnership, our Safer Northumberland Partnership, stripping it back to core responsible authorities to make sure that we are working as collectively as possible. We've got a very robust, Graham and Neil, safeguarding boards across adults and social and adults and children. but we do have a gap that is in development around an economic partnership. There's a number of different forums where private sector, large industry meet, and then public sector, which is largely ourselves, and then voluntary sector tries to jump between. There is an opportunity to create an economic family that brings private, public sector and voluntary sector together as entities for us. But what we want to have sitting above that at the most strategic level is a Northumberland County Partnership. This isn't unusual. It exists in many other areas. Durham has one, for example. I think North Tyneside has one. But this is about the Health and Wellbeing Board, and whilst we might want to, can't do it all and shouldn't do it all. So it's about bringing the most senior people together above that. And the common purpose that they are very, very interested in is to tackle inequalities, because it's something that will make a difference to everyone. So since July, our last inequalities event, was a shadow meeting held last October with core partners to say, are we interested in coming together as a county partnership, and for what purpose? And the overwhelming response was absolutely yes. So the kind of membership that we're talking about is the likes of the Chief Executive from Benicia, John Johnson, it's Chief Officers from the Chamber of Commerce, it's Vice Chancellors from Northumbria and Newcastle University, it's Sam Renison, Area Commander from police, and then it's Graham yourself from ICB. So it's bringing together the core partners from business, private sector, from voluntary sector and from public sector as well. So that's the premise behind it. And the first inaugural meeting is proposed to be on the morning of the 17th of April, ahead of the showcase event that I know you'll have all been invited to. But what's running alongside that to act as our catalyst in many ways and to catapult us further is a contract that is actually jointly funded between local authority and the ICB to work with the Institute of Health Equity. You'll recall last July we had Dr. Jessica Allen present at the July Inequalities event, and that was the start of the conversation about how they're really keen to work with us in Northumberland, and that's because of the unique nature we want to tackle inequalities by taking this strength and assets-based approach. So what I just want to highlight is a bit more detail that this will be a 2-year relationship that we will have. And the first year will have a deeper dive on housing in particular and good and fair employment. So whilst we have our inequalities event on the 17th of April with the spotlight on voluntary sector, police and fire, we're proposing the October event, and you heard from Anne Lawson and Rob Murphin, there will be a focus on housing and health and what are we doing in that space. And then in year 2, we'll be moving towards employment and health feedback, and then looking at best start in life also. So we'll be enable us to have the statistics and look at that over the longer period of time. Because what we have agreed, and it's brilliant to have elected members all agreeing this, is that this is generational change. This can't be achieved in political cycles. It has to be at least a 20-year ambition for us to start to close those gaps that you saw in Luke's presentation around healthy life expectancy and life expectancy. That will not change in 4 or 5 years' time without doubt. But what we do want to do is to be able to track our progress, and how we model future state will be a key thing for us to keep momentum, but also to keep people's buy-in is really critical. So this just highlights, if you're not familiar or if you can't quite recall, the 8 areas of the evidence base that says if we focus on these, we will be able to start to drill into those stubborn inequalities, start to level off, and ideally start to close them off. But what is really exciting is how we do that and how we demonstrate that and how we measure it. So I've talked about the statistics, which is what the Institute will help us to do in that 20-year ambition and our stretch targets along the way. So where are we at 2024, where are we at in 2028, and so on. Our surveys will complement this. We've just been out for a resident survey, but in schools we do things like the health-related behaviour questionnaire survey, and we'll be able to spread those out into, well, what does that look like in Blythe, in Bellingham and in Berwick, so we can start to understand the within county inequalities, because that's where we will start to get the richness. But what is The newer aspect is how we focus on storytelling and create case studies and vignettes to be able to show what it's like to live in Northumberland now, but then what's it like to live in Northumberland in 2028 or 2032. And if any of you have ever watched 7 Up on the TV, or if you're aware of Bourne and Bradford study, it's of that ilk that we want to generate, but not with the research component of it, but it's more live ethnography of being with proactive consent, people wanting to tell their stories and us to be able to share them and upload them. And the way we want to do that is we're required to have a joint strategic needs and assets assessment. It's a pretty pedestrian document at the minute, website. It's quite 2D, it's the data, and you can drill in and you can see IMD, you can see child poverty. We do high quality deep dive needs assessments, but it's still the statistics, and we want to go live and be much more vibrant, and that's where the stories will come in and generate that much more I suppose visual, and we're referring to it as a living archive, and that's the proof of concept that we're going to be designing. We're going to take to the first county partnership meeting, and if we get that buy-in, then that's what we want to work alongside the institute, but also our local academic institutes, Newcastle and Northumbria, are very interested in working with us on that as well. But the bit that I wanted to specifically focus in on for yourselves this morning is the governance of all of this and how we all knit it together. Because when I was working with Jessica and to Professor Michael, they were saying, well, we need a board and we need this person on it and this person on it, this person on it. They were describing our health and wellbeing board because we've got such a good, vibrant board here already. So the proposal is the county partnership will meet 3 times a year, April, July and October. 2 of those, April and October, we will breathe out and have wider stakeholder events, which will be where we showcase the inequalities work, and we'll hand that baton around the systems so people can tell their story of what are they doing in relation to tackling inequalities. But actually, the Health and Wellbeing Board can be the advisory board to the Institute and to basically manage the contract as a collective, because this should not be just between the ICB and public health. We've all got a part to play in how we shape that 2-year relationship. And then there'll be a number of key colleagues across organisations that will be pulled in to do focus groups and insight work, pulling strategies and documents so that the Institute can create the diagnostic for us to give us our feedback and say, this is what you're doing really, really well. This is a gap for you. This is a blind spot for you. We think you've got good traction. You could go further, faster over here. So the ask really to enable this to happen is to have once a quarter a single agenda item, Health and Wellbeing Board, where Michael Marmot and or Jessica Allen come up and work with us specifically to talk about where we're at with the work and where we want to be, which will then inform the county partnership discussions and also the showcase events. But something for us to consider is, do we want to continue with those ones, bearing in mind their development planning kind of conversation? Would we want those to be held in open forum as we currently have, or should they be closed development discussions whereby we might want to be out of the chamber, a partner might want to host us, and it's a bit more dynamic because it's a planning development conversation with the Institute. It would be core membership, but then we would look and take advice from yourselves. Who else might we need around that table? Because the deep dive topics, for example, in year 1 will be housing and good and fair employment. So I'll pause and open that up for the chair to coordinate discussion.
Suggestions. So maybe we can leave this as it is, closed or open meeting. I'm more inclined towards closed meeting because it is single agenda item, so we will be discussing over that one. Any suggestions on A or B or C? Oh yes, please, Sam. Yeah.
Chair, I think the benefit of closed meeting when we talk about single agenda item allows really focused conversation.
That is correct.
The environment you hold that conversation in is also really important around making sure everyone around the table understands that they've got something to give and we need to come up with a solution. Sometimes open meetings can be really difficult for people who've got really good ideas and opportunities to feel comfortable and confident to have to pass that.
Yeah, I completely share that view with you. Are there any? Yes, please, Peter.
Thank you. Whole series of excellent reports I haven't commented on through the entire meeting, but I support them all. I'm with you. I'd recommend the closed approach. I think we get more, probably get better value out of it.
Yeah, put our heads together and discuss freely. Yeah, that would be nice. Okay. On point B, we can always, if it is closed, we can always move around. There is no reason that we should be meeting only here. Of course, this could be a default position. Veronica, you want to say something? No? I'm okay. Sorry.
This is something where I think the board have to
Yeah, the board has to decide as well. So there is, we can ask our partner to host, and we can go around, familiarize ourselves with the different environment. On C, yes. I'm sorry, Sam again.
The other benefit of going out is I think it's really important for our business to see that partnership really together.
Yes.
So actually, we within this room recognise that we work really well together as a partnership, but actually how much of our workforce understand that this partnership is working really well together and going on the road in different bases provides that visible visible presence outside of the normal core members.
Yeah, that's an excellent point. Yeah, yeah. Any other? Peter, please.
Yeah, I think it'll certainly well-facilitated off-site discussions in a kind of workshop environment, I think, would really add value to these to this direction.
Yeah. I think that point is also valid. You see, when we say meet somewhere else, the workforce of that place will understand there is something else our organization is involved in. So that would be a very good opportunity as well. Right. So, point number C. I think core membership plus additional senior representatives to reflect the deep dive areas. I completely agree with you, Jill. So I think probably we will leave that to you to discuss who can be brought in depending on the special interest themes and everything. So looks like we have made a decision as a board, or decisions, 3. Yeah. Thank you. So we move on to 2 minor items. Where am I? I lost the agenda. Sorry. Here it is. Yes. Forward plan. I think next meeting will be on 11th April, isn't it? That's where we are discussing health and well-being strategy. Yes. That would be a very interesting meeting as well. There is no urgent business as far as I can see. So that brings an end to this meeting. Thank you very much for all the reports, for all the questions and suggestions. Thank you very much. See you on 11th of April.